everybody. How are you doing tonight?
Great.
Good. We have all ladies here. Now, doesn't have to be a ladies' event, but so be it. We're here to talk about menopause. And this is going to be fun, whether you pre, post, or don't even want to know about it. We're going to learn a lot about menopause, hormones, kind of a lot of questions might come up at some point. I'd like to introduce Dr. Holly Sato, who is a fine OBGYN who just dashed over from the OR after finishing a case, so she's revved up, maybe relaxed now. So her dossier, she received her undergraduate degree in biology from the University of Puget Sound, and then her medical degree from the University of Washington, woohoo, UW, and completed her residency at the University of Rochester Strong Memorial Hospital. She then completed a fellowship in robotic and pelvic surgery at Northwest Hospital Medical Center in UW. So I think before coming here, you were Swedish, and we're delighted to have you in our robust, all-female OBGYN department. So we do have a little bit of different lecture style tonight. We have both Men for Change and Partnership and Health folks. We have little treats over to the side, so please help yourself. And I'm just going to turn it over to Dr. Sato.
So tonight we're going to talk about menopause, and we're going to try and talk about everything from like the perimenopausal, which is honestly what I think a lot of people think about when they think about menopause. It's all this perimenopausal stuff leading up to not having a period anymore, and then talk about a little bit about treatment and various symptoms of menopause. So
I will demonstrate the hot flash.
yes, right here we have it for you. So, okay. So menopause is technically defined in medical books about not having a period for 12 months and without any other causes of not having a period. So we always think about things like pregnancy. I've had patients who show up 46 years old, they say like, I haven't had a period for 3 months, and we do a pregnancy test and it's positive, and they're shocked because they think they couldn't get pregnant. So I always tell people, if you're having a period, there is a possibility. And then there's some other kind of more rare things that can cause people to not have periods for an extended period of time. And so because it is the absence of something, it can only be determined retrospectively, but oftentimes people can kind of tell that they're going through menopause through various symptoms that they're having. The average age of menopause is 51, and it varies greatly among women. So genetics is a huge factor. So whenever I see patients, I always ask when female members of their family went into menopause, because if they say like, oh yeah, my mom didn't go into menopause until she was 58, chances are she probably won't either. Ethnicity also plays a role in it. People who are in the Latina population tend to go into menopause earlier, and then the Asian population a bit later. Smoking, people who smoke tend to go into menopause earlier. And then what I think is kind of interesting is people who have had a hysterectomy, even if they've had their ovaries left in place, will actually go into menopause earlier than women who have not had a hysterectomy. And the thinking behind that is that when you do a hysterectomy and leave the ovaries, you probably do affect the blood supply to the ovaries, and so they therefore then can't make hormones as long and as well. And so people who've had a hysterectomy, even with their ovaries left in place, will go into menopause 2 to 3 years earlier than they probably would have otherwise. So like I said, perimenopause is kind of what I see a lot of people for, and this is basically the menopausal transition that occurs after the reproductive years, but before actually having menopause. And so a lot of people have irregular cycles during this period of time. They have endocrine changes like the hot flashes and other different symptoms. And the average age is about 47 years old. Though recent studies have showed that people can have up to 10 years of perimenopausal symptoms before not having a period anymore. So I think that this is a thing that people need to be aware of, and like that they don't kind of have to just like suffer through it very much. So this is kind of just a staging system that they look at from reproductive years as you go into menopause. And so we're kind of looking at this little box in the red. And I'll just talk about it a little bit more in depth here. All right. So to determine if someone's gone through menopause, women who are older than 45, we really just talk to them and see what their periods are doing, what their other symptoms are, and we don't really usually check blood levels. And so one of the questions I get a lot is people come to me and they say like, I want my hormones checked. And so this is kind of like, in the land of OB/GYN, we don't routinely check people's hormone levels. And the reason why is they can fluctuate greatly on a day-to-day basis depending on a multitude of things. And if people are still having periods, they can vary greatly. And so it's just not a lot of very helpful information that tells us where people are at in kind of the menopausal transition. But there is something called a follicle stimulating hormone. So this is basically the hormone that your brain makes and sends messages down to your ovaries saying like, make estrogen, make estrogen. And so if your body's not making a lot of estrogen, your body will start to make more of this follicle stimulating hormone. So people who, if we do check an FSH level, it's usually decently high in people who've gone through menopause. Now in women who are 40 to 45, we kind of determine if they're perimenopausal or menopausal in the same way by just talking to them and seeing what's going on with their periods and their symptoms, but we do want to rule out those other causes like I talked about earlier. And then it used to be called premature ovarian failure, but we don't want to, like, that sounds kind of mean, though primary ovarian insufficiency doesn't sound much better, but basically it's when people go into menopause when they're less than 40 years old, and this entails like a huge workup to kind of figure out why and then to mitigate some of the risks for that and kind of beyond the scope today. So, and then just some other kind of categories of women who the diagnosis might be a little bit harder to figure out is women who have never really had regular periods. Sometimes they're like, I don't know if I've skipped a period for 3 months just because that's how I am, or if I'm actually going through menopause. So you can check an FSH level at that time. And then I do have women who continue on to birth control pills well into their 40s and early 50s, especially if they have a history of like really crazy periods. And so those birth control pills can alter people's follicle stimulating hormone level, and so we generally have them stop their pills for 2 to 4 weeks and then check a level after that. And then if someone's had a hysterectomy or an ablation, which is a procedure done for women who have heavy periods or frequent periods where you kind of go in and you burn the lining of the uterus. And in about 30% of women, they won't have any more periods. And so if you don't have a uterus or you don't have a uterus that is having a period, it's sometimes hard to determine if you're in menopause or not. So again, you can check in that FSH level. And so these levels that are like between 25 and 70 can indicate perimenopause, but again, those levels can fluctuate a lot, and so it's only so helpful. And then greater than 70 is pretty suggestive that someone's postmenopausal. So symptoms, so in the early perimenopausal state, that's where people's periods start to kind of space out. So instead of having that classic like 28 to 32 day cycle, people start to have 40 to 50 day cycles. If you check someone's FSH level, it might be high, but it might not. And that's where people, they can have some of those menopausal symptoms like hot flashes, but they're not usually too bad at this point in time. And then as people get into the later perimenopausal cycle, that's where they really do start to skip cycles, where people are like, I haven't had a period for 3 or 4 months, and then they'll get one. And then we see a lot of what we call anovulatory cycles. And so this is basically where your kind of balance of progesterone and estrogen is a little bit off. And so you don't have as much progesterone, and then it causes the uterine lining to become really unstable. So people can have really prolonged periods of bleeding, sometimes for several weeks. Sometimes it can be really heavy. And so those are due to those anovulatory cycles. And this is where people do start to get more of those hot flashes, which we like to call vasomotor symptoms. Oops, sorry. And then postmenopause is when people's FSH is really pretty high at that point. And really people shouldn't have any bleeding once they haven't had a period for a year. And if people do, you definitely should like call your doctor and talk to them about it, because almost always it's benign, but very rarely it can be an indicator of abnormal cells in the uterus. So it's always important to let someone know if you have bleeding after not having a period for a while. So to talk about more of the symptoms, so everyone thinks of hot flashes when they think of menopause, and so this is the most common menopausal symptom. Over 80% of women will experience this, so only 20 to 30% of people will actually go and see someone for this. Risk factors for having hot flashes include obesity, smoking, if people are not as active, and ethnicity as well. So one more reason to stay nice and active to decrease your hot flashes. So about 40% experience it kind of early on, but then like up to 80% of people will experience it through those later phases of perimenopause and early into the postmenopausal period. And so basically what happens is that estrogen is involved in thermoregulatory dysfunction, and so when you don't have as much estrogen and you have like a small increase in your body temperature, usually your body can handle that, but with less estrogen, your body starts to open all its blood vessels and basically people get really flushed. They describe this kind of starting up in the chest and the face and then extending over to the rest of the body, lasting for a couple minutes. And then afterwards, because people have oftentimes like started to sweat during this, people then start to get really chilled, sometimes anxious afterwards. And so a lot of people experience these symptoms for over a year, and it can really affect your quality of life. And usually they will resolve after 4 to 5 years, but up to 10% of people will still have these symptoms well into their 70s, so they can last for a really long period of time. So yeah, you're like, yeah. So sleep disturbances. So as you can see here, experienced by a lot of women going through the menopausal transition as well. And what I think is interesting is that, you know, a lot of people like have night sweats, which are just hot flashes that you get at night. But a lot of women, even if they don't have hot flashes or night sweats, a lot of them still have sleep disturbances. And so this has been associated with a lot of depression and anxiety, and it's a little bit hard to say like what comes first. You know, are people not sleeping well because they're anxious and depressed because they are going through menopause and that's also a big time of change in people's life, or is it kind of the other way around? And this definitely is a period of time where people do start to develop other medical issues. It can affect quality of sleep. They might be getting started on medicines. It can also affect quality of sleep. So, you know, it's good to look at other causes of why people might not be sleeping. And so to talk about depression, there is really a significant increase in new onset depression when people do go through the menopausal change. And so they had this really great study where they followed women for 8 years as they went through menopause, and there was a 2.5 times more, they were 2.5 times more likely to be diagnosed with depression as they went through menopause compared to premenopause. So it really, those hormones really do affect mood for sure. And of course, if someone has underlying mood disorders or a history of underlying mood disorders, they're definitely at higher risk for developing depression or anxiety during the menopausal transition. So this is another thing that I see a lot of women for during the menopausal transition, and it makes me happy that I'm starting to see a lot more people about it, because I think a lot of people come to me and they're like, I just figured that this was just how it was and this is how I have to be and I have to settle with it. But so a lot of people get vaginal dryness and because of that sexual dysfunction when they go through menopause, and so the vagina is very, very dependent on estrogen. So as we make less estrogen, the lining of the vagina starts to become thinner and more fragile, so people can have a lot of vaginal dryness, itching, burning, and pain with intercourse. And as you can see here, it's experienced by like half of postmenopausal women. And the symptoms usually start out mildly, but then as people go through menopause, they do kind of progressively get worse over time. And so, as you can see up here, there are a lot of changes in the vagina and the vulva that happen when people make less estrogen. So the vagina becomes more pale. Usually the vagina has lots of folds in it, but those folds start to flatten as people have less estrogen. There's decreased pubic hair. The elasticity and the turgor of the skin also decrease, which causes narrowing of the vaginal opening. And sometimes can cause fusion of the labia minora to the labia majora, so, and also decreased blood flow to the vagina and vulva. So you put all of these things together and people can have a lot of vaginal pain as they go through menopause. And I'll talk a little bit later about what we do for that. And then in terms of cognitive changes that happen when people go through menopause, there's a lot of like good biological basis for estrogen. There's a lot of estrogen receptors in the brain, and often a lot of those receptors are in places that deal with memory and learning. And so people always say like, oh, when I went through menopause, I just like couldn't remember things like I used to. So there definitely is like a biological cause for that. What's interesting is it doesn't really pan out in like studies of like dementia and that sort of thing. So, but I still think that you can blame some of your postmenopausal brain on being postmenopausal. And then other kind of long-term consequences are bone loss and osteoporosis, heart problems, arthritis, a change in body composition. So a lot of people start to can lose some of their lean mass as they go through the menopausal change, and they start to have more like central fat deposition. So there are a lot of body changes that happen as people go through menopause. There's also a lot of skin changes which people notice. The skin is made of collagen, which has a lot of estrogen receptors. So as people make less estrogen, the elasticity and the turgor of the skin decrease. So people notice more wrinkling and thinning of skin. And then estrogen is actually pretty involved in balance, so people are more likely to fall once they become postmenopausal, and then you couple that with bone loss, and you're definitely at higher risk for fracture once you go into menopause. Okay, so to talk about treatment, so hormone replacement therapy basically in the early 2000s got a bad rap. And it's mostly due to this Women's Health Initiative study, which was, I mean, I'm glad they did this study. It was very, very important. But basically what they did is they looked at women who were either put on estrogen alone or combined estrogen and progesterone or a placebo pill. And they saw what happened, you know, in terms of their menopausal symptoms, and then they looked at the side effects. And basically they found an increased risk of cardiac issues, stroke, venous thromboembolism, which is blood clots, and breast cancer. And this increased risk was so profound that they actually stopped the study early. And then they did another analysis of these 18 different trials, and in the USPTF, that stands for United States Preventative Service Task Force, they basically make a lot of like screening guidelines in the medical world. And basically they found a very similar thing, and so because of that, everyone was like, you shouldn't be on hormone replacement therapy. And prior to the study, about 22% of postmenopausal women were on hormone replacement therapy, and after the study, it fell to about 5%. So it was a pretty significant drop. And so I do think it was important to do this study, but it was somewhat of a flawed study in terms of applying it to like women going through menopause. So the average age of a woman in these studies were over 60, and so these women basically hadn't seen significant amounts of estrogen for over a decade, and then all of a sudden they were being put on it. So that's not necessarily like the women who are going through menopause. So it's not really applicable to women in their late 40s, early 50s who are going through menopause. And so then this little chart here, so basically this looks at women like 50 to 59 years old and looks at their risk of various things when being either on estrogen. So we put people just on estrogen if they've had a hysterectomy, and then we put people on estrogen and progesterone if someone still has a uterus. And the reason why is if someone has a uterus and you just put them on estrogen alone, it predisposes them to having abnormal cells in the uterus. And that can occur after only 6 months of being on it, so it's really important to be on both estrogen and progesterone if someone has a uterus. But as you can see here, there is still a little bit of an increased risk of heart disease, breast cancer, and then blood clots and stroke. Heart disease and breast cancer with estrogen and progesterone. And then stroke, blood clots with both estrogen alone and estrogen and progesterone. But it's not as significant as was found in that original study. So, for example, for heart disease or breast cancer, if there's 2.5 more cases per 1,000 people over 5 years of either heart disease or breast cancer if someone's on hormone replacement therapy. So the findings weren't as drastic as was initially thought based on that study that was done in 2002. So when looking for like people who are good candidates for hormone replacement therapy, it's generally people who are less than 10 years from menopause, less than 60 years old. They don't have any contraindications to hormones, so they don't have a history of breast cancer or heart disease or previous blood clots or stroke or any liver disease. And really, mostly what hormone replacement therapy is used to treat is those hot flashes and to treat the vaginal atrophy. And really, we don't use it so much to treat chronic conditions like osteoporosis because there are much better treatments for that have less risk. So to talk about kind of different hormones, so estrogen. So there's many different ways to give people estrogen. So most people think of taking a pill, and you know, it's less expensive. It's been around forever. That's what was actually studied in that Women's Health Initiative study. So some people feel more comfortable with taking that because that's what's been studied. And it does increase what we call sex hormone binding globulin. So basically this is a protein in your blood that binds up excess testosterone. So sometimes women like that because it can help with things like acne or sometimes hair loss since you don't have as much free testosterone circulating around in your body. One of the kind of downsides of the pill compared to the patch is so the patch actually has a lower risk of blood clots and stroke. And so a lot of people will go with the patch first just because of that. So if someone's like pretty healthy and you know early on in the menopause transition, I think you know it's worthwhile to do the pill if they want to. And then there's gels and skin sprays, though like I've never prescribed those to people. Most people in my practice don't. I think they're just harder to use, and there is always the worry about it rubbing off and like transferring to someone else. So those we tend to not use as much. And then if people are really just having vaginal symptoms, so we can give estrogen vaginally, and there are 2 vaginal rings. One delivers as much estrogen as you would get with a pill or a patch. Then there's another ring and cream and a pill that they all can go in vaginally that are just local, and so you don't have the systemic exposure to estrogen, so you don't have the risk of blood clots and stroke that you do with like the patch or the pill. And then one of the most common side effects of taking estrogen is people get breast tenderness, and it does seem to be dose related. And so in terms of progesterone, so for women who have a uterus and need some progesterone, there's a couple different ways to give it. So you can give it orally. There's so many different preparations of progesterone in terms of pills. And you can take it cyclically, meaning that you just take it for 12 days of the month. And that's better for people who are still having periods and having a lot of menopausal symptoms, or if they've recently just stopped having a period. And by taking it cyclically, they have less irregular bleeding associated with it. But if someone's been menopausal for a while, you can do it continuously where they take it every day, and they tend to not have really any bleeding with that. And then you can give progesterone also through an IUD, which is a little T-shaped device that is mostly used for birth control. Well, it's FDA approved for birth control, but we use it for like a billion other things. It goes inside the uterus and slowly releases progesterone over time. And so I like this just because it really limits systemic exposure, and it's just in the uterus working where it needs to. But it's not FDA approved for this, so a lot of insurances won't pay for it. And then common side effects of progesterone, I always tell people, are like the less serious side effects, but like the really annoying ones. And so those are mood changes, bloating, and then some irregular bleeding. So in terms of vaginal atrophy, people can use what we like vaginal moisturizers. So these are just products that you can buy over the counter. and Replens is a very common one, and they're basically just things to add moisture back into the vagina. For mild atrophy, it's actually been shown to be just as effective as using estrogen, though in my experience, for people who have more moderate to severe atrophy, it's not enough. And so also for vaginal atrophy, it's kind of like the use it or lose it principle. So they've done studies that show that women who have regular intercourse, or whether it is penetrative intercourse with a partner or with masturbation, that they actually have less pain and less vaginal atrophy. And it's probably because it helps to keep those tissues elastic, and then it also helps to increase blood flow to the vagina. So, if people don't have a partner, you can actually send them to pelvic floor physical therapy, which always sounds a little weird when I tell my patients about it, but I'm like, there are so many women who need pelvic floor physical therapy because the pelvis is a whole bunch of muscles, that there are 4 people at the polyclinic who that's all they do. So it's a really, really common thing to go see a pelvic floor physical therapist. And then people can buy dilators. So I have a little 80-year-old patient who bought these dilators on Amazon. She's brought them to me. She's like, I hope these ones are okay. And I was like, dude, those are awesome. I can't believe you did that on your own. You're amazing. So yeah. And then people can do vaginal estrogen. And like I mentioned earlier, I like vaginal estrogen. People are just having atrophy symptoms because they don't have the systemic exposure, so they don't have the risk of blood clots and stroke. And I always warn people, when they pull out the little pamphlet from their vaginal estrogen, it's going to say in big letters, this will increase your risk of blood clots and stroke. And unfortunately, the way things are packaged, it's the same for oral estrogen as vaginal estrogen, even though the risk is not actually in fact the same. And then there's a newer product that was approved in 2013. It's called Osmina, and it's a SERM, which stands for Selective Estrogen Receptor Modulator. And basically what it is it works at the estrogen receptors and helps the body to make more estrogen. And this Osmina actually works just locally in the vagina. And I haven't used it a ton just because I'm just so much more familiar with vaginal estrogen, and people do experience pretty significant hot flashes with Osmina, so you're kind of trading one thing for another, I feel like, with Osmina. So. And then there's this really cool thing called the Mona Lisa Touch, which is a CO2 laser, and basically it's a nice way to do a non-hormonal treatment of vaginal atrophy. And there's an internal laser that goes in the vagina, and then there's also an external one that goes on the vulva. And basically what it does, it doesn't hurt, but it makes little tiny microabrasions within the vagina to help increase the blood flow to it. And so again, that can really help with atrophy. And people need 3 treatments about 4 to 6 weeks apart at the beginning, and then they kind of come in for a yearly maintenance type of thing. So most insurances don't cover it, so that's kind of the downside of that. So this is another thing I get asked about a lot, is I want something that's bioidentical. So bioidenticals are hormones that have the same molecular structure as what we make in our body. And so bioidenticals that are FDA approved are actually the estrogen patch, and then prometrium, which is the progesterone. And so I think that what most people think of as bioidenticals are actually compounded hormones, and so those can come in a variety of forms, as you can see here, and then a variety of different routes. And so the dosing of these kind of compounded bioidenticals are done based on hormone levels, which can either be done by a blood test or a cheek swab. And the problem with these bioidenticals is there's just not a lot of safety data around them, and so because they're just made by various pharmacies and there's not a lot of regulation around it. And one study showed that these bioidenticals that people were getting, that the amount of hormone that was actually in them was anywhere from 65% to 200% of what it said actually on the packaging. And so just because of that, like I generally don't recommend compounded bioidenticals to my patients, but there are a lot of people in the Seattle community who do them. So my kind of approach to starting hormone replacement therapy is if people are having significant vasomotor or atrophy symptoms, if they recently kind of gone through menopause or are going through the menopausal transition and don't have any contraindications. And then I use these two tools to assess people's risk for cardiovascular disease and then also breast cancer risk, just to make sure that they're good candidates and that I'm not increasing their baseline risk too much by giving them hormones. And then we do the lowest, I kind of start at people at the lowest dose possible for the shortest amount of time. So I don't usually start them on like the lowest dose of progesterone. I kind of do a medium dose, and we can always taper up or taper down. And then we kind of I have people check in with me each year and I see how they're doing, and we do start to talk about weaning off at 5 to 10 years, just kind of depending on how they're doing. And I like to do the estrogen patch and Prometrium. That's kind of my go-to. If someone's up for an IUD or their insurance will cover it, then I like that as well. And then if people only have vaginal symptoms, I just give them some vaginal estrogen. And so behavioral changes, I think a lot of people already have done these by the time I see them, but people, just lowering the ambient temperature, dressing in layers, avoiding things that trigger people's temperature to rise, having regular exercise, not smoking, layering their bedding, sleeping with a cold pack underneath their pillow so you can flip-flop your pillow so it's always cold at night. And then doing this paced restoration, which is kind of like yoga breathing, where you breathe in through your nose and out through your mouth and really slowly. Doing like 5 to 6 breaths per minute can also help to make your hot flashes kind of go away a bit faster. So talking about non-hormonal treatments for mostly, these are mostly vasomotor symptoms, but some other things as well. So some women don't want to take hormones, some women can't take hormones, and so there's definitely a lot of other stuff we can do just other than hormone replacement therapy. So SSRIs and SNRIs are antidepressant medicines, so things like Paxil, citalopram, or all those different ones up there, venlafaxine, desvenlafaxine. So those have been shown to help decrease hot flashes in women. I have a few patients who kind of go this route, and I've had variable response with people. With people, they're typically not as strong a response as like hormone replacement therapy, but I think for some patients it actually does help pretty well. Anti-epileptics like gabapentin or pregabalin, and so these medicines are used for so much more than seizure disorders. They're used for like a ton of other things, and hot flashes are one of them. And these are really good if people have hot flashes just at night, because both of these medicines can be somewhat sedating, and so people get a good night's sleep and they have improvement in their hot flashes. And then clonidine, which is a blood pressure medicine, we tend not to use as much just because it has a ton of side effects that most people feel like it's not worth taking. And then other things, so CBT is cognitive behavioral therapy. It's basically a certain type of counseling, and basically that's been shown to be really good for sleep. So they had a study where women were randomized to 8 weeks of CBT versus just like education about menopause. And at the end, they answered this like little questionnaire and said like, how many of you had no more insomnia after this? And 70% of women who did CBT actually had no more insomnia, which I think is pretty impressive. And that was comparative to about 25% of people who said that just with the education. And then hypnosis actually might help with hot flashes. So they randomized women to 12 weeks of hypnosis, and then after that they saw how many what their decrease in hot flashes were, and women who did hypnosis had 6 fewer hot flashes versus women who didn't, who only had 1. So that could be another possibility. I get asked a lot, should I like eat more soy in my diet, and because these have to do with like phytoestrogens, and so I tell people it's fine to do. Like in studies, it hasn't been shown to be better than placebo, but I don't think it has a lot of harm in it. Same thing with black cohosh, which is an herbal remedy that a lot of people ask about for hot flashes. Again, no benefit over placebo, and there was some concern that it might affect people's liver function, but it didn't really pan out that way. So again, I say, like, if you want to try it, go ahead. And then all these other things, you can see acupuncture, flaxseed, evening primrose oil, again, not been shown to be better than placebo. And it's interesting, in studies done with for vasomotor symptoms with placebo, there's actually about a 40 to 50% response rate with placebo, which I find really interesting. So, and then this is just a graph that shows kind of the up on the top, the blue circle is black cohosh and the green square is soy, and then some like vitamins and placebo. And you can see that there was a decrease in symptoms, but not as much as some of the other things like the SSRIs. Yeah. And then the other thing that I always point my patients to is the North American Menopause Society. So they have tons of great information for women just about menopause, about their symptoms, about various different treatments. And so I send a lot of people there as well. And they look like they're having so much fun going through menopause, right? Yeah. They're like, it's great, I love my hot flashes. So, yeah. Right. Any questions?
Well, I have a kind of a complicated question. A number of years ago in our program here, we had a lecture by Dr. Gordon Irving, who maybe he's retired now, but he ran the Swedish Pain Clinic. And his topic was pain in the brain. And I remember like slide 50 in a slide deck was about evening primrose oil.
Yeah.
And it was on very high dose evening primrose oil, like probably maybe 7 or 8 times what you normally just get in the bottles at the store, as being helpful for a pain response in the brain. I'm just curious if the studies you're citing, or if you have any other knowledge about something like that, because that just always kind of surprised me.
Right, yeah. I mean, I don't really know any studies. I mean, I'm trying to think about it in like perspective to, you know, to menopause, and just like maybe with high enough levels, it is somehow stimulating those estrogen receptors, because people do get a lot more joint pain and aches and pains once they go through menopause. So maybe at those super high doses, it is affecting that. Yeah.
Thanks.
Yeah.
If you were on the pill for a long period of time, does that make menopause happen later?
Not necessarily. One of the reasons why we try not to keep people on the pill for a super long time, and this actually just came out like a few months ago, is just because there is an increased risk of breast cancer. And you know, it's an increased risk. It's still an overall low risk. It's like, it was something like for every woman who'd been on birth control for like X amount of years, there'd be one more case out of like 1,700 women or something like that. But yeah, it doesn't necessarily affect when you're going to go into menopause.
I don't know what I'm going to, but I'm not going through a lot yet.
Yeah.
All this stuff, do most women have to do some of this, or do some women go through it less than others?
Yeah,
No
so
idea.
there are a few like really lucky women who are just like, I stopped having periods and that was it. Like, they didn't have hot flashes, they didn't have sleep changes. And I tell them, like, you're really lucky, and don't tell your friends, right? And so I would say, like, most people do, I would say, like, most people are middle of the road, where most people do have hot flashes. I mean, I would say that's the biggest one. It's pretty rare that people have those hot flashes, like, once every hour when they're really bad, but some women do, and if people are having hot flashes, like, every hour, every other hour, or waking up 3 or 4 times at night because they're having hot flashes, like, you know, that's pretty severe, and that's probably when they need treatment. And things are also pretty gradual. So like when you're saying like, I don't know where I am, it's because it is a gradual change. Like, people will be like, well, maybe I had a hot flash last week or something, but then they might start to get more. So it is kind of hard, and like I was saying, like, we used to just think like, oh, people go through this perimenopausal phase for like 3 years or something, but now like people are experiencing it for up to a decade, and so it can take a long time to get from point A to point B, and that your symptoms and the journey through that can be really different along the way.
Oh, you had sleep apnea up there. Is that related to changes in hormones? for women, or?
Yeah, that's a good question. I think it possibly could be, just because again, like your tissue is changing and like the elasticity of your tissue is changing. So, but really, I put it up there more as just like, you know, when people transition from their 40s to 50s, it just is a big change. The other reason why it might be related is just because people's body composition changes. And so if people are starting to get a bit more, you know, fat tissue, and then their tissues kind of aren't as supportive as they used to be, then it would predispose them to something like apnea.
So someone who's, you know, pushing 10 years into menopause and still having hot flashes noticeably.
Yeah.
So I'm getting the impression you can just pretty much expect that to continue.
Yeah. And I mean, so people, usually it does die down, but like I said, like about 10% of women in their 70s still do have significant side effects. And so, you know, we used to have this like, after 5 years, you need to be off your hormones. And now I still think it's like a big conversation you have to have with people about, because if like, and we usually taper people off their hormones so we don't like stop it all at once. Though interestingly, like, it doesn't really matter if you stop it all at once or you taper it off in terms of because people do have some rebound symptoms as they do that. But I think it's just important to talk to people, because if people overall are, you know, relatively healthy and they're having really significant symptoms, it might not be worth it to go off their hormones after 10 years. Because then if they're not sleeping or, you know, or other things that are affecting their quality of life, that's probably a more significant impact than their risk of, you know, a blood clot.
Yeah. Is it kind of normal for, as that lucky 10%?
Yeah.
It seems to cycle.
Yeah.
Where they kind of peak, where it's very often, and so that's kind of normal.
It is really normal.
I just want to, I always try to say, okay, what's going on? Why am I having so many?
Yeah.
Kind of a thing. And I've never been able to see a pattern, but.
Yeah, and it's really, it's something you like, it could be based on so many things, right? So like people usually notice like with the season changes, they notice a lot of things. So, but it can be a multitude of things. It can be like stress related. It could just be, I mean, it's so hard, and it's so hard because your body is just saying like, I want more estrogen, but you don't have any, so then you get these crazy hot flashes and stuff. But it is really normal. I have some people who are like, I was fine for 3 months, and I was like, yay, I'm finally done, and then like nothing changed, and all of a sudden they're back seeing me because things are pretty significant again.
I do have to just toss this in.
Yeah.
My placebo supplements.
Yeah.
Actually, I don't care why,
Yeah.
but they do seem to help.
Right,
And
and
if
that's
if
kind
it's
of,
all up here, I'm good.
then
with
hey,
that.
that's good, right? No, I agree. That's why like when people are like, should I try this? I'm like, if you want to, go ahead, because it's really, there's not a lot of harm in trying it, and so, and if it works, then it works, you know?
But there used to be conversation about phytoestrogens linking to breast cancer.
Right, yeah, but not so much,
Okay.
yeah. Yeah. Yeah.
Some naturopaths say that you can have actual estrogen dominance during menopause. Is that kind of unheard of, or
Estrogen dominant.
where they would say, you know, you're getting, you know, estrogen and not progesterone?
Yes, I think, yeah, I get what they're saying. So progesterone plays a role in this as well. And so for some people, actually on the last slide I didn't mention it, but some people will actually put people on just progesterone for hormone replacement therapy and not necessarily give people estrogen. I would say that that's like a smaller category of people, and I don't know if there's a great way to determine if people have estrogen predominance other than like if they did, I don't know what the naturopaths do, if they do a cheek swab and kind of look at their hormone levels. But yeah, I do have a few patients who are just on progesterone alone, and so that helps to decrease some of those risks for things like blood clots and stroke as well.
Well, thank you for coming. This has been really fun to learn about. Do you want to stay late and ask questions? Otherwise, have a great evening.